This program is brought to you by Emory University.
It is truly an honor and my privilege to introduce Dr. Sumeet Chugh, who is Pauline and Harold Price Professor and Associate Director of the Schmidt Heart Institute at Cedars-Sinai in Los Angeles. He's also the Medical Director of the Heart Rhythm Center and Director for the Center for Cardiac Arrest Prevention at Cedars-Sinai, as well as the Director of Artificial Intelligence in Medicine in the Department of Medicine and Professor at UCLA. Dr. Chugh received his medical education from Government Medical College in Punjab, India, followed by his internship in internal medicine at Tufts Newton Wellesley Hospital, and then residency at Hennepin County Medical Center. He trained in cardiology at University of Minnesota and was a fellow at Mayo. He joined faculty at Oregon Health and Sciences University in Portland and was chief of EP there. And then about 12 years ago, moved to Los Angeles to direct the Heart Rhythm Center. Dr. Chugh's groundbreaking work includes establishing a real-time population cohort, which was one of its kind and very innovative at the time, following the Oregon sudden unexpected death study, which is what he created, and also the PRESTO study, which I think we'll hear more about today. Dr. Chugh is the president of EP Society and Association of University Cardiologists. He serves as a secretary treasurer for them and also a member of the American Society for Clinical Investigation. He's received numerous outstanding awards and amazing teacher and extremely generous with his time, training lots of fellows. And without further ado, I will turn it over to Dr. Chugh. Thank you so much for doing this for us.
Thank you, Dr. Mehta, for that wonderful introduction. And it doesn't need to be said, you're greatly missed by your patients and your colleagues at Cedars-Sinai. It's really a privilege to be joining this remarkable cardiology division where so many have learned so much over the years. Thank you very much for the kind invitation. Dr. Taylor, Dr. Wenger, Dr. Langberg, Dr. Kayumi, Dr. Cho, and many others in the audience. Today, I'm going to talk about sudden cardiac death and some novel approaches that many of us are trying to take to prediction and prevention. I don't have any disclosures. We have current research funding from NIH. As this group knows rather well, sudden cardiac arrest is generally defined as a sudden unexpected loss of the pulse due to a cardiac etiology. It's a sizable public health problem. In the US, about 350,000 sudden cardiac arrests happen on a yearly basis. Around the globe, it's a little harder to count, but estimates range between 5 to 7 million a year, making up a large chunk of cardiac mortality. And as we know, it's a unique condition where you're going to have death within 10 minutes of presentation, unless, as shown on the left, someone can reach you quickly and start the life-giving cycle. And with cardiac arrest, this nice-looking EKG turns into either a ventricular tachycardia or ventricular fibrillation, and increasingly pulseless electrical activity or asystole in terms of the proportions, and we'll come back to that in a little bit. If we look at data from emergency medical services, these folks in the trenches really make remarkable efforts. Despite these rates of sudden cardiac arrest survival around the nation are in the range of 10%. So by the time 911 is called, it's really too late for about 90% of people. As we know, time is myocardium, bystander CPR is important, followed by the chain of survival with early access, early CPR, early defibrillation, and early advanced care. To this chain of survival, I've taken the liberty of adding early prediction and prevention. Because if we're going to make an impact on this rather complex condition, then there's going to be a key role for prediction and prevention. Here are some household names that have suffered sudden cardiac arrest. Some of them were in their middle age. Jim Gandolfini, it's no secret, had a bunch of risk factors, died suddenly without much in the way of warning. Carrie Fisher, on the other hand, had a myocardial infarction. Tom Petty also had a sudden cardiac arrest with some warning symptoms. On the other hand, Tim Russert actually had a normal stress test a week before he died suddenly in the absence of warning symptoms. And it doesn't just strike folks in middle age. If you look at examples of the least vulnerable, as we think about of it, the athletes that could live forever, both Hank Gathers and Reggie Lewis died on the court. Both of them had symptoms, but refused to give up. On the other hand, shown in the middle here is Ryan Shea, the U.S. hope for the 2008 Beijing Olympics. He died in the 5th mile of a training marathon in New York City. And if you look at what we know, some of it from autopsies that are publicly available, there's a range of conditions in the older folks, coronary artery disease, in the younger, hypertrophic cardiomyopathy, and perhaps in Ryan Shea, even idiopathic ventricular fibrillation, that present differently, present at many ages. But there's one thing in common between all of these household names that had a cardiac arrest. Their cardiac arrest could have been preventable. So what I'd like to start with is to discuss the current approach and why we need to enhance our approach to prediction and prevention of sudden cardiac death, and why we've been using a population-based study design. And I'll share with you some novel predictors, mostly from, in the interest of time, from our work, but some from others. And then some thoughts about how we could translate this kind of discovery into clinical care. The primary prevention defibrillator, shown here on the left, the drawing is by Michelangelo. This is a collage, and the defibrillator is by some company. But the reality is, as shown here on the right, whether it's overdrive pacing or anti-tachycardia pacing from the device, or it's ventricular fibrillation recorded from the leads with a life-giving shock, this is a remarkable device. Within 7 to 8 seconds instead of 6 to 8 minutes waiting for the ambulance, this is your personal paramedic. The main predictor in common forms of cardiac arrest it has always been the left ventricular ejection fraction, in the range of less than 30 to 35%. Based on some rather well done primary prevention clinical trials. And the class 1 indications remain fairly steady, where you treat the patient optimally for heart failure, should have a reasonable expectation of survival. But in the end, it's really all about the ejection fraction in common forms of cardiac arrest, like coronary disease and most of the dilated cardiomyopathies. We're realizing, though, in recent years, that there could be subgroups that may not benefit as much. So the Danish trial shown here showed no mortality benefit of the defibrillator in non-ischemic cardiomyopathy, whether it was death from any cause, cardiovascular death, or sudden cardiac death. And it's a good-sized trial. And the point to take away from this is that whether, even if you combine the anti-tachycardia pacing and the shocks over a year, it was well below 4% in terms of the therapies received from the device. However, there are some unique aspects. 60% of patients in either group were getting biventricular pacing. And it is possible that if you look at the subgroup of patients under the age of 60, that there was benefit as opposed to the patients who were older, 60 and above. Here's another example. The ICD-2 trial was conducted in patients with ejection fraction over 35%, because with the recognition that patients who have end-stage renal disease also have a high rate of sudden death. But as you can see, the summary is that defibrillators don't deliver in dialysis, even when you look at a subgroup over the age of 35%, of the ejection fraction over 35%. And so on the left is shown the cumulative incidence of sudden cardiac death. On the right, any change in survival, and there are no differences between the control group and the defibrillator group. In fact, over a 10-year follow-up, there was a pretty high complication rate. And so this trial was terminated for futility. So why there were sudden deaths, but the ICD did not help. And one of the possibilities is that a lot of these patients have their sudden death with non-shockable rhythms. And we're going to come back to that as well. So today, over time, the primary prevention defibrillator is showing some diminishing returns. Many who get a primary prevention defibrillator are not actually going to use it. So for ejection fraction less than 35%, we are implanting more defibrillators over time, but we need better risk stratification. So why is that? So this is this figure in the center is from a very interesting meta-analysis published 4 years ago, 3 years ago now, where Lin and colleagues showed that if you look at over 40,000 patients enrolled without defibrillators in about 12 trials of heart failure drugs over time, 1995 to 2004, in this blue line, you can see that even without defibrillators, there was a sizable reduction in sudden cardiac death over time. And in fact, I've taken the liberty of drawing this red line that goes through the placebo group for these heart failure trials. And you can see a significant drop in sudden death, even in the placebo group. So what's really happening is that we're doing much better with heart failure management, with awareness, get with the guidelines. And so the number needed to treat in heart failure patients is really increasing. So from about 20, it's anywhere between 30 to 99 patients who need a defibrillator every year to save one life. And that probably is not sustainable. So that's really why for patients with ejection fractions less than 35%, we need to do a better job. So we recognized about 2 decades ago that there was this unmet need where we needed some kind of, it was not a mystery that we needed a better risk prediction score beyond the ejection fraction. And so I called up studies like Framingham and realized the numbers were too small to do any kind of meaningful analysis, because out of 5,000, maybe 2 to 4 every year would have a cardiac arrest. So we moved to this model where in the interests of numbers, we moved to a population-based approach where an entire large population was treated as a cohort. And this work has been accomplished really with the help of the community itself, with partners in the community, as I'll show you, especially the folks who respond in the ambulances. This is all about out-of-hospital cardiac arrest. So if we're going to ascertain patients in the hospital, it's only in the emergency department. But of course, it's a partnership with the hospitals that gets us all the clinical profile of all the patients. So we have been using 2 communities as population cohorts. The first one was the sudden unexpected death study in Oregon. We started in 2002 and we're in our 19th year. Shown here on the top left is Portland, Oregon, with the Willamette River flowing through it. And almost 6 years ago now, we started in Ventura. It was really a way of having a validation cohort that would be similar to Portland, Oregon, with some interesting differences, of course, in terms of ethnicity, where Ventura is 42% Hispanic Latino. And so what we have done over the years is, and Ventura is shown here a beautiful part of the country as well. So we have about 1 million people who live in the Portland metro area whom we have followed for over 19 years, and about 850,000 in Ventura, California, in this county, whom we have followed for almost 6 years with partnerships in the community. And the design is shown here for the ascertainment of cases. We prospectively ascertain cases, but everything after that becomes retrospective. So most cases come from the first responders, 911 calls. Some come from the medical examiner, and very few from the hospitals, under 5% from an emergency room. Over the last 19 plus years, we have ascertained over 11,000 presumed cardiac arrests. What starts then is a process of retrieving individual level data. We don't do coded science. Each patient's lifetime clinical record is reviewed. We review any autopsy data that's available, pre-hospital data, and we perform an in-house adjudication for sudden cardiac arrest, keeping in mind that it's not perfect. Our best shot is to maximize the signal and minimize the noise. We really ascertain folks who don't survive, but also we follow people who survive. So it's about sudden cardiac arrest, whether you make it or not. And we're now at a number that's approaching 9,000 sudden cardiac arrests. They're in a clinical database. Each has over 800 variables from their lifetime clinical history, tests done, labs conducted, clinical events that happened, anything that potentially could be related to cardiac arrest. We study the epidemiology, and then we have a biobank. It's something that we started out with, and it worked, where you would argue that, well, how do you have a biobank if not everybody gets an autopsy? Well, it turns out that at the time that the emergency medical services response happens, standard operating procedure, of course, is to insert an intravenous line and to pull back to make sure you're in the right spot. And that flash of blood generally is tossed in a Sharps container, and we've been saving it for 2 decades. And we can make DNA out of that small amount of blood. Sometimes we have a little bit more. We make plasma. And so if there's an autopsy, we are able to get a small piece of tissue. And from survivors whom we consent, we can get a blood sample for proteomics as well. So it's sort of a multidisciplinary approach to try to get at this using this population-based strategy. And so we have a geographically matched control population, both in Oregon and in Southern California, and the sources are the same. These patients are, of course, alive. And the design for most of what I will show you is that at least 70% of patients have significant coronary disease, because in the end, coronary disease is still the biggest player in the etiology of cardiac arrest. But of course, the controls don't have any history of cardiac arrest. Again, for them, we have a clinical database and we have a biobank. So here's early data from the Oregon study. And this is work presented by Eric Stecker, who was an intern then, but is associate professor of medicine now. With ejection fraction less than 35%, Eric showed this was an imperfect predictor. Also because the majority of patients who have a cardiac arrest really have preserved ejection fraction. And shown on the left, in folks who had an echocardiogram done before and unrelated to their cardiac arrest, half of them had normal ejection fraction, a fifth had mild to moderately reduced ejection fraction, and only 30% had severely reduced ejection fraction of the kind that buys you a defibrillator. So very similar data was reported from the Maastricht study in the Netherlands with a very similar design. So the reality is that even today, in common forms of cardiac arrest, at least 70% of these events are going to be missed if we go by the current guidelines. So not only do we have to do a better job with ejection fraction less than 35%, we have to do a far better job with ejection fraction over 35%. And when it comes to women, we have to work even harder, because the reduced ejection fraction as a predictor is even less effective in women. When you compare to men, shown here in blue, women are in pink. There's a much lower prevalence of severely reduced ejection fraction, half the amount, and women are far more likely to have normal or moderately reduced ejection fraction. So there is an equal opportunity for risk prediction yet. So over the years, several efforts have been made, good efforts, at trying to create some kind of risk score. Here's one from the atherosclerosis risk in communities and the cardiovascular health study, a combination of these two cohorts. And Raj Deo, Faye Norby, and colleagues did this work. A combination of demographic factors, cardiovascular disease risk factors, some serum measures, the QT interval on EKG, etc., resulted in improved prediction of sudden cardiac death, but alas, also an improved prediction of non-sudden cardiac death. So the knowledge gap here is that we need specific predictors for sudden arrhythmic death. That's really what the defibrillator is going to fix, is a shockable rhythm, either ventricular fibrillation or ventricular tachycardia. So what we did, and this is relatively recent data, we've tried to address this knowledge gap for prediction of sudden arrhythmic death. And as electrophysiologists and cardiologists, we reach for the oldest test, the most widely available, least expensive test, and that's the resting 12-lead ECG. So we have this design where at least 40% of patients whom we ascertain have had an ECG that we have now digitized and stored that was performed before and unrelated to their cardiac arrest event. And over the years, we have taken markers, and others have taken markers from the ECG and independently found association. So we had at least 9 markers that we had written about. And in the end, what we did was we put them together. And so in a model, 6 of these markers emerged as being independently associated. And when we combined them, and these were resting heart rate over 75 beats per minute, QRS transition after V4, electrical LVH from the ECG, abnormal frontal QRST angle, the QTC interval, and the T peak to TN interval as shown here from the peak of the T wave to the end of the T wave. And so we evaluated whether a combined ECG risk score would do a good job at predicting sudden cardiac arrest beyond the ejection fraction. And here in a nutshell are the data. This was a team approach. It was led by Dr. Apo Aro, who's now back at the University of Helsinki, was a postdoc with us during that time, and Darren Rainier, our lead epidemiologist. And so on the left is shown the odds ratio as the number of ECG abnormalities out of the 6 increase. And as your risk score goes from 0, meaning no abnormality, to 4 or greater, the odds of having cardiac arrest increase significantly, and on average are 20. And if you take ejection fraction over 35%, they actually increase to 26. Now, the idea was, okay, so this is Portland, Oregon, the Oregon sudden death study. Well, how about replicating it? And so on the right is shown a replication in the atherosclerosis risk in community studies, which is really from cohorts around the US. And we expect, because they come in as having no apparent heart disease, compared to our control population, that actually at least 70% of them have significant coronary disease. We expected a smaller number, and we did, but the risk score was predictive in this population as well. As you can see on the right, the cumulative incidence of sudden cardiac death increased as the risk score from the ECG increased. Dr. Rainier also looked at cumulative effects on sudden death risk from the echocardiogram. So if you just look at ejection fraction less than 35%, the odds ratios were 2. And if you just look at left ventricular mass calculated from the echocardiogram, the same echocardiogram as the ejection fraction, independently the odds increase by 2. But if you combine them, the effect is additive. So this is really a concept where combining these 2 simple parameters from the echo improved risk prediction for sudden cardiac arrest. And on the right is shown how left ventricular mass was independently predictive in the Cupio prospective cohort study, just like we found in the Oregon study. This is very recent data and also deals with the echocardiogram. This was performed by Sumeet Pandit, one of our residents in internal medicine at Cedars-Sinai. Now he's a cardiology fellow at Baylor. And Sumeet found an association between right ventricular dysfunction, is sort of like the neglected ventricle for cardiac arrest. But these are, again, patients who had a cardiac arrest compared to control patients, mostly with coronary disease, in a smaller subgroup because we looked at digital echocardiograms. And the assessment of right ventricular systolic dysfunction was made by the right ventricular fractional area change, as you know, pretty easy to calculate it from the echo. And for a 5% decrease in right ventricular fraction area change, or VFAC, the odds ratio increased by 1.14. This was adjusted for age, sex, diabetes, hypertrophy, left ventricular ejection fraction. The C statistic improved. As you can see, cases have lower RVFAC, and cases are more likely to have a combination of lower RVFAC and lower left ventricular ejection fraction. This is data from upstate New York, from Moss, Zariba, and colleagues from the MADIT CRT trial, where over time, as you follow these patients who have biventricular defibrillators, and you use occurrence of defibrillator therapy as a surrogate for a cardiac arrest event, then over time, as you go from less remodeled to more remodeled or eccentrically remodeled hearts, as measured by the relative wall thickness calculated from the echocardiogram, you have increased risk of recurrent ventricular arrhythmia as measured by recurrent shock. So eccentric LV remodeling in heart failure in CRT patients with ICDs also increases risk of sudden cardiac arrest. So the kind of concepts that we are working on is that, say that you had risk markers on the same echocardiogram where you just use the ejection fraction. How about just measuring simple parameters like left ventricular mass using the modified American Society of Echo equation, left ventricular geometry, right ventricular systolic function? Could we improve individual risk? I'm going to shift gears into rhythms. And as I had brought up earlier, the message, there's a new message from the emergency medicine world for out-of-hospital cardiac arrest and even in-hospital cardiac arrest, that in the last 3 to 4 decades, there's been a paradigm shift in how cardiac arrest actually presents. We used to think that most of the time it's ventricular fibrillation, ventricular tachycardia, and it was. Well, what's happening is that the proportion of cardiac arrests that have shockable rhythms is actually reducing, and the non-shockable rhythms are going up. And it's really important for obvious reasons, because if you look at survival from the shockable rhythms, VF or VT, it can be as high as 25 to 40%. But if you look at non-shockable rhythms, asystole, PEA, anywhere from 1 to 5% or 6%. And of course, there's no specific treatment for PEA. A lot of times, there's no point. So since the automated external defibrillator, or the AED, and the implantable defibrillator, today, that's the only kind of therapy we have for shockable rhythms, there are implications for primary prevention. So this is very recent data from the Oregon study, where if you look at overall cardiac arrest and heart failure, well, there's a significant overlap. These are two conditions that overlap a lot. And when we look at heart failure itself, one way to subcategorize it is that there are 3 kinds of subtypes. One we call HFrEF, with ejection fraction less than 40%. At the other end is HFpEF, ejection fraction, say, over 50%. And we've started talking about this subgroup in the middle, where the ejection fraction is 40 to 55%. Some folks call it HFmEF, heart failure with moderate reduced ejection fraction. Some will call it borderline HFpEF. Whichever way you look at it, we don't really know how the shockable rhythms present in these subtypes. So we hypothesize that the rates of shockable rhythms in the end, those are the treatable ones, would vary based on heart failure subtype because of the distinct differences, it seems, between these three subtypes. So in the Oregon studs, we studied almost 650 patients with both heart failure and sudden cardiac arrest, with a median age of 72, uh, uh, about 270 with HFrEF, 280 with HFpEF, and about 92 here with borderline HFpEF or HFmEF, as they call it. And if you compare the three groups, here's a summary of the data that HFrEF, ejection fraction less than 40%, and borderline HFpEF or HFmEF, 40 to 50%, look more like each other. When it came to sex, obesity, hypertension, coronary disease, COPD, and shockable rhythm. Survival to hospital discharge was the highest in borderline HFpEF. And HFpEF was quite different from these two. In fact, when we looked at the proportion with shockable rhythms, you can see the best likelihood of shockable rhythm is in borderline HFpEF, similar to HFrEF, and much smaller in HFpEF. And shown here, adjusted, again, the highest chance of having a shockable rhythm was in borderline HFpEF. So we think that over time, these data about shockable rhythms are going to be quite important when we're going to get to a renewed phase of doing clinical trials. But whichever way you look at it, we're really trying. The reason that we're growing our numbers even today is that we want to look at cumulative risk patterns in the sudden cardiac arrest phenotype. It's not just about ejection fraction. We have to get away from that. Sudden cardiac arrest is a prototypic complex trait. Coronary disease is a big player, but so are genetic factors, underpinnings like diabetes, obesity, hypertension, hypertrophy, lifestyle, and then who's going to have a shockable rhythm and who's not. So we have at the Center for Cardiac Arrest Prevention at Cedars-Sinai, we have this ongoing pheno mapping project, and we hope to do a better job with cumulative risk patterns. And the idea is to come up with some kind of risk prediction tool for sudden arrhythmic death. Who's going to get ventricular fibrillation or ventricular tachycardia? What we have available are some electrical markers, some imaging markers, clinical risk markers. But we want to get at not just the vulnerable ejection fraction, but the vulnerable myocardium, the vulnerable interstitium. And how do other systems, for example, the autonomic nervous system, interact? And what's ongoing is we're doing some genomics work. We are pretty close to getting our whole genome sequencing done on 3,000 well-phenotyped sudden cardiac arrests. We have made a foray into some proteomics, metabolomics, and we're also looking at some novel imaging. We're combining some machine learning algorithms because the data is becoming so large, especially as we get to phenotype, genotype, that it's quite challenging to do it just with conventional analyses. So we're using an approach. We're doing conventional analyses, and we are comparing those to machine learning algorithms. So if we do have a sudden cardiac arrest risk score, and we're actually pretty close to the phenotype, and with time hope to get to the more complex scores, we really have hit an impasse, because if we do have a cardiac arrest risk score, there are all kinds of competing interests here and complications. So how are we going to do this? Well, we think that today, the primary prevention defibrillator really is a shared decision-making process. And to some extent, we have extended a little bit beyond the ejection fraction. This picture is taken from the Canadian guidelines that actually have, within the guidelines, a 7-point frailty score. It's becoming clear to us that there is a competing risk of mortality in our patients as we assess them. And so we now have to really think about, with our patient, is this ischemic cardiomyopathy, non-ischemic? What's the age of the patient? What are the comorbidities? Is something else going to get them before the defibrillator saves their life? And so whether it's ejection fraction less than 30% or 30 to 35%, we can do a little bit more. However, we need to do much more. And tomorrow, we need to really have a better handle at the risk of dying from non-sudden death. How do we exclude those patients that are not going to be helped by the ICD? And we have to hit this sort of intermediate risk group, because the risk of cardiac arrest is going to be really low in the low risk group, and the high risk group might have competing risk of mortality. So as time goes on, in fact, these are trials that are active. The VA cooperative I-70 trial, which is in VA subjects over the age of 70, is actually comparing ICD versus no ICD for primary prevention. There is equipoise for it today. The trial is active, not recruiting. I haven't seen anything yet, but we should hear from them soon. Whether it's for ejection fraction less than 35% or over 35%, there has to be a combination of prospective observational studies and pragmatic and randomized clinical trials of the ICD to test broader risk prediction instruments beyond the ejection fraction. In the last few minutes, here are some questions that we get asked a lot, and here's some data, largely from the Oregon study, because we're still accumulating numbers from Presto or the Ventura study. And if you look at exercise, even in middle age, especially in middle age, the burden of sports-related cardiac arrest is low. The news is really good, where less than 5% of cardiac arrests over the years have been related to any kind of sporting activity. And if you look at this graph, the overall numbers become really tiny for even our youngest. But the youngest have another issue here that we should briefly talk about. And this is work that was led by Reshmi Jayaraman in our group and published about a couple of years ago, where we evaluated the burden of sudden cardiac arrest in the young, meaning age 5 to 34. And it took us a while because fortunately, these cardiac arrests are rare, and there's really no other community-based data. It's really a collection of data from different parts of the US and different parts of the world. But this is from a community of almost 1 million people over 14 years. And as you look at this graph, and this is age on the x-axis, number on the y-axis, and shown in red are the proportion of cardiac arrest related to sports activity. And in the younger population, it's about 14%. So the vast majority are going to happen in the absence of sporting activity. So it turns out that really where we have to work probably is that we found a very high prevalence of conventional cardiovascular risk factors in this young population. At least 60% had at least one or more risk factor for conventional cardiovascular risk factors. So whether it's diabetes, hyperlipidemia, hypertension, obesity, smoking, we really have a lot to do to prevent sudden cardiac arrest in the young, even while they are young. From other studies like Bogalusa, we know that we'll pay for it when we're older, but we could pay for it even when we're young. We get asked this question, or people want to ask, that what about sexual activity as a trigger for cardiac arrest? And so Dr. Aro looked at this about 3 years ago, and the news again is pretty good. There's a very low prevalence of cardiac arrest related to sexual activity. It comprised less than 1% of all cardiac arrests. There's some interesting findings here. 94% of our subjects who had cardiac arrest with sexual activity were men. But I'd like to draw your attention to this number at the bottom. Only 1 in 3 men actually got bystander CPR. They had a partner right there, but still weren't lucky enough to get bystander CPR. Of course, the popular press really caught on to this. And I'm going to show you a headline that really I found very interesting. Maybe not as illustrated or illustrious a journal, but here's the Australian saying, "Sex may not kill, but your lover might let you die." So, so far, I've been talking to you about the long game, which is predicting cardiac arrest over time, potentially years before it happens. But those of you who play golf know that unless you have a decent short game, you aren't going to get anywhere. And so this is what I'm going to end on, where we are pretty excited about this work that was done from the Oregon study, led by Xavier Jouvin, who's back at the University of Paris now doing some remarkable work. And from the Oregon study, Elwa Marijan, Elwa basically looked at warning symptoms in the 4 weeks prior to cardiac arrest. Generally, we ask about immediately prior, and he found that at least 50% of both men and women had warning symptoms. What is important is that he also showed that these symptoms, when they happened immediately, were ignored by the vast majority. About 80% of folks ignored their warning symptoms. Well, the ones who didn't and the ones who called 911 actually had a 5 to 6-fold higher chance of successful resuscitation. So this made us sit up a little bit and start thinking about, well, what about near-term prevention? Is there a new window of opportunity here where we're trying to do long-term prevention, but we've coined this term near-term prevention, where perhaps in the 4 weeks before cardiac arrest, if we could figure out who has warning symptoms and is destined to have this sort of imminent cardiac arrest, maybe we could also prevent cardiac arrest that happens in the last 4 weeks. And so this is really a concept that we have put out there. It is the subject of a grant from the NIH that we received earlier this year, and we're working on this. And the idea is that if everyone in the community who had chest pain or shortness of breath called 911, then within 2 hours, the Atlanta metro area emergency medical services would be completely overwhelmed. And so the idea is that out of this ocean of people who have warning signs of some kind listed on the left, maybe we could try to find the sea of people who have warning signs but are destined to have a cardiac arrest. And so the concept is that if we combine the warning signs with the clinical profile of the patient, but also with some novel markers in the proteome, which we've been working on and discovered with our collaborator, Dr. Van Eyck at Cedars-Sinai. So if you were in an urgent care and you want to know which patient to admit, or the ED, or perhaps in the future, even the community, because mobile and wireless technology is taking us places, then your smartphone could tell you, well, you have warning symptoms, and this is absolutely an emergency, call 911. Of course, not something we can deploy right now, or maybe it's less emergent and you could see your doctor later. So just to end with a summary of what I've discussed today, that when it comes to sudden cardiac death prediction and prevention, yesterday we were looking at just the ejection fraction, but over time we're finding a smaller benefit from the primary prevention ICD. There's also competing risk of mortality from comorbid conditions and in non-ischemic cardiomyopathies. So today we're trying to balance, to some extent, arrhythmic risk with non-arrhythmic risk. When we have the conversation with our patients, we're doing some shared decision-making that accounts for age, frailty, and comorbidities. However, tomorrow, we're hoping to have this cumulative risk prediction tool that's more specific for arrhythmic death, shockable rhythms, where we can use potentially ECG, imaging markers, blood, proteomics, genetics to do a better job. But of course, before we get there, we need prospective studies, prospective clinical trials in high and intermediate risk populations. And also keeping in mind that this sort of new idea, new paradigm of warning symptoms and near-term prevention could also be another way of getting at cardiac arrest. So I've showed you data that has really been collected by these stalwarts at the Center for Cardiac Arrest Prevention at the Sumeet Heart Institute at Cedars-Sinai. And we're funded by NIH, as well as generous support from the Cedars-Sinai Health System. Both Oregon SUDS and Ventura Presto are a team sport. We have remarkable colleagues in the community shown here on the left, both in Oregon and in Southern California, and other colleagues that we collaborate with. And there's a deep appreciation we have of the communities in both of these regions, as well as the providers who work with us on a daily basis to get this done. I'll stop here Thank you very much for your attention.
Thank you so much, Dr. Chugh. That was just amazing. We are going to take questions, and while people are typing their questions in the chat box or texting me, I'll start off with a question. I thought that the data that you presented on sex differences was very interesting. And so not only do women have more preserved EF, but have sudden arrest, but women also have more non-obstructive CAD and tend to have sudden arrest. So I was wondering if you have any insight into that. Have you looked at predictors of what's happening here in women?
Yes, very good question, Dr. Mehta. This is really a hard question to answer. We've looked for the low-hanging fruit. Um, we've looked at more common clinical profiles. We've looked at the common markers. As best as we can tell, there are some clues, for example, on the ECG, but they don't stand out. So we really need to take a renewed look. It's not an easy question. And the best that we can do is that every study we do related to cardiac arrest, we should make sure that we have enough in the way of numbers. Part of the problem is that if you look at most of the prospective studies that have been done in the past, women were really not well represented. Whether it's a clinical trial, there was overwhelmingly men. But honestly, whether there's something on the X chromosome, whether there are some proteomic markers, at this point, we don't have a lot of clues. We've got a lot more work to do.
So in general, men are more likely to have sudden cardiac arrest, correct? Like if you look at the just pure numbers.
That's correct. So women actually have, if you look overall, an advantage here. So in the Oregon studies, as in other studies, it's 65%, 35%, or 70% men and 30% women. So there are some advantages that women enjoy. What is very interesting in terms of differences is that as they present, women are actually more likely to have non-shockable rhythms, which is so interesting, but the survival outcomes are about the same. So in some ways, women also enjoy maybe a slight advantage for survival, but really, in the end, risk prediction is not as good in women as in men, and we don't have very good answers yet.
Thank you. Any other questions from the audience?
Yeah, this is Andy Smith. I've got a couple of questions. One, as B-type natriuretic peptide testing becomes more common as a screening tool for left ventricular dysfunction, are you incorporating that into what you're looking at? And then the second question is related to the short-term issues. Any comments related to heart rate variability, which I know in heart failure often increases weeks before a heart failure event, but is there a way to look at heart rate variability with things such as an Apple Watch or that type of thing?
Very good questions. Thank you for asking those. And you're right on the mark with BNP, especially NT-proBNP. There's work from Dr. Albert and colleagues and others where it's a marker for sudden cardiac death. And so definitely we are always measuring NT-BNP, proBNP when we get a chance. And we don't have data for you yet, but hopefully we will from the Oregon study as well. In terms of the Apple Watch, and heart rate variability. So over the years, there was a lot of interest in heart rate variability. Unfortunately, there are as many papers shooting it down as the number that actually brought it up. We are actually interested in another marker that plots heart rate variability against the resting heart rate. And that's a very interesting marker. We published recently, and it seems to separate diabetics with sudden cardiac arrest. When you plot heart rate variability on the y-axis and resting heart rate on the x-axis. So I think in an indirect way, heart rate variability is going to come back, but not quite in a direct way. I see a couple of more questions on the chat.
Yes.
Is it okay if I start addressing those? Very nice note from Dr. Koyumi here. And yes, he mentions that, the group at Emory has a biobank of patients undergoing catheterization and is enriched for people with coronary disease different from our population. And there are more than 1,000 deaths. And you bet, Dr. Koyumi, I think we should have another conversation and could really be a great group to have a little bit of a collaboration and think through this together. The more heads on this, the better. So I will be in touch, and we should chat more. And here's a question from Dr. Neil Dickert. This paradigm of shared decision making in this space is interesting. Conceptually, it's invoked in situations where there are risks and benefits on both sides and where patients' values and preferences are likely relevant. In these circumstances, the issue seems more of one uncertainty about what individual risks and benefits actually are. To what extent do you think that sharing the decision really helps address this issue when patients have no more insights into the risk-benefit ratio for them? I think you hit upon a very, very challenging issue. And to a large extent, you are correct. And what I mean by shared decision making here is that if you look at the number needed to treat, any number between 33 and 99 per year is not great. And so if we just make people aware of the fact that, even if you look at the older data, the absolute benefit in terms of number of months you gain of life is not a lot. And if you look, and as an electrophysiologist, to be very honest, I implant these. If you in certain patient groups, especially in older patients and with risk of mortality and competing risk, I think we should just make patients aware of it and what the downsides of having an implant over time is. So there are actually some efforts through Heart Rhythm Society. While their initial forays, this is actually now a Medicare recommendation as well for shared decision making, increasingly beyond the societies. And we do need some more work. There are some prospective questions that are being asked in this space. We hope to do a better job over time.
Dr. Chugh, does exercise change with QT help predict anything?
Yes, so very good question. If we look at the subgroup of patients with rare conditions, specifically, certain forms of long QT syndrome, it turns out that sometimes when you just make the patient stand and get an ECG, you can get a prolongation of the QT interval. Sometimes if you exercise the patient, you can get a prolongation of the QT interval. However, in the more common forms of increased risk of cardiac arrest, the QT with exercise has not been shown to be any kind of risk predictor. The QT interval is very interesting in the sense that it may not be as specific as we'd like it to be, because we find that it prolongs in lots of conditions other than cardiac arrest as well. So we've found that the T peak to Tn interval is probably more specific than the QT interval, even in common forms of sudden cardiac arrest. But in the risk score that I showed you from the ECG, we're actually combining these 6 markers that we think do a better job than individual markers.
Okay, thank you. Thank you so much. Are there any other questions or comments? Okay, Well, we're getting close to time here. So Dr. Chugh, again, thank you so much. Really appreciate you doing this so early in the morning for you. And I look forward to meeting with you right after this. And thank you all of you for joining, and we'll close Grand Rounds.
Thank you very much.
The preceding program is copyrighted by Emory University.